Okay, this is going to be on Chapter 25 in your Med-Surg book on assessment of the respiratory system. Basically the structures and the functions of the respiratory system. The primary purpose, of course, is gas exchange, which means bringing in oxygen and exhaling carbon dioxide. You have an upper respiratory tract and a lower respiratory tract. The upper respiratory tract, that is, excuse me, is the nose, mouth, pharynx, epiglottis, larynx, and trachea. Air enters in through the nose, and the purpose of the nasal mucosa, it warms and moistens the air as it enters the nose. This is why people that are on oxygen, a lot of times when they have the nasal cannula with the oxygen, their nasal passages get all dried out because it's just dry oxygen going straight in. So often we will hook up a humidifier to it so it warms and humidifies that air. The lower respiratory tract, consists of the bronchi, bronchioles, alveolar ducts, and alveoli. Other than the right and left bronchi, all lower airway structures are found within the lungs. The right lung has 3 lobes, an upper, middle, lower, and the left lung has 2 lobes. It's an upper and a lower. Why do you think? Why do you think the right lung has 3 lobes and the left lung has 2 lobes? Well, your left lung is going to be making room for your heart. So if you even look at the diagram, you can see here that the left lung is kind of a little bit funky shaped, and that's just because it has makes room for the heart. I already talked about that. Nose, there we go. You can see all that, the upper, and then here's the lower. The trachea and the bronchi is basically what's called dead space. There's no gas exchange there. The bronchioles has smooth muscle. It constricts and dilates. And then the alveoli, that's the very bottom portion of the respiratory tract. They look like little bunches of grapes. That's where the gas exchange takes place. As you can see, here's a picture of they look like little grapes. They're very thin-walled so that the gas exchange is able to take place there. That's where it pulls in the oxygen when you inhale, and the carbon dioxide is released so that you can exhale the carbon dioxide. Surfactant, it's a lipoprotein. It is inside of the alveoli, and it keeps them from sticking together. It basically helps them stay lubricated where they don't stick together. Atelectasis, that's you see that a lot on x-rays, and it just means collapsed alveoli. So sometimes some people have some collapsed alveoli, and that will impair their gas exchange. With the blood supply, so basically the blood supply, you will have the blood coming from your heart that's deoxygenated coming to the lungs. It'll go down and down to the alveoli. That's again where the gas exchange will take place. Your chest wall, you have your ribs and sternum that protects your lungs and heart. Your pleura. The parietal is your chest cavity, visceral is lungs, your intrapleural space, and it has a little bit of fluid in there to help with some lubrication. Sometimes you'll have some what they call pleural friction or a pleural rub, and that is when there's some inflammation and that pleural space and it's rubbing. Your diaphragm is a very large muscle, and that is what helps with your respiration. Inspiration is when it contracts and you're breathing in, and of course then you have expiration. Innervated, you don't need to know all that. Oxygenation, oxygen from the atmosphere to the organs and tissues. Oxygen that's dissolved in plasma is your PaO2. Normal is 80 to 100. And then you have your oxygen bound to hemoglobin, and that's your SaO2. And that's typically what that higher than 95%. So again, here it talks about inspiration, expiration. Elastic recoil is that the lungs return to original size after expansion. Some people lose that elastic recoil, and that makes breathing more difficult. So that's the compliance is it's the ease of lung expansion, the elasticity and elastic recoil. Decreased, it would be hard for the lungs to inflate, or increased would be hard for the lungs to recoil. Your airways can constrict, and they can dilate or constrict. Constriction, they could be, they could even have like different secretions, like a lot of mucus secretions, like if you have a lot of allergies, or an illness. The medulla in your brain is part of, it's in your brainstem, it's the respiratory center. And then you also have chemical receptors. You've got hydrogen ions, and if you have an increase, that can cause acidosis, which will have increased respiratory rate, or you can have decreased hydrogen ions, and that can cause alkalosis. These are things that we do not need to worry about right now at this point. And again, this is stuff you'll learn further on, but and you may have learned some of this in anatomy, physiology. You also have some different receptors that respond to stimuli, obviously things like irritants. And what do you think that would make you do? Make you cough. Different defense mechanisms. You have like little cilia that's like little hairs in here. You've got goblet cells. These all, your cough reflex, these all help protect your lungs. There's a picture of lungs. Okay, so again, shows here inspection, palpation, percussion, auscultation, different assessments that you would see. You would see, like with somebody with pneumonia, they're going to have some tachypnea. They're going to have increased fremitus. The percussion is going to be very dull, and you'll hear bronchial sounds early. Asthma, you can see the different, basically the different conditions between pneumonia, asthma, atelectasis, and COPD, where it'll sound different. COPD, somebody's very barrel-chested, and you're going to hear some crackles in the lungs. When you're performing an assessment, of course, you take your health history and your physical exam. Ask the patient if they're ever short of breath during exercising. You want to get all the subjective data, basically the past health history, respiratory allergies, any medications they're taking, even over the counter, any surgery. Subjective data would also be smoking history. Any respiratory problems? Do they cough? when they cough, is it productive? What does it look like? Have they traveled internationally? What about their immunization status? Ask about their genetic risk. Any family history of cystic fibrosis. Could have COPD, could have asthma. Some people are predisposed to bronchitis. Also ask about their nutritional status, elimination pattern, if they have any incontinence. And again, activity and exercise. If they have limitations due to difficulty breathing, and if there's any positions that they take that maybe make it worse or make it better. And if they have any difficulty doing ADLs. Some functional health patterns, that's their sleep, rest pattern. Do they have problems sleeping, breathing at night? Do they need to prop themselves up on like a couple of pillows? Do they have any pain with breathing? And of course, we always need to get all the social history stuff here. Especially look here with work. Are they exposed to any kind of toxins? Coal, fibers. Obviously, somebody that says, oh yeah, I'm a coal miner, well, you can pretty much assume that they're going to have some lung issues. What about hobbies? Maybe they like to do woodworking, so they've got a lot of those dust and particles that could be irritant. And of course, we still continue on with sexuality, coping, stress. Now the objective data. Now remember, subjective, that's what we're asking. That's when we're interviewing them. Now the objective is what we're going to see as we are doing our assessment. We're going to do our vital signs, look at our pulse oximetry, see how well what their oxygen saturation is. We're going to look at the nose for patency or any inflammation. Mouth and pharynx. We're going to look at the gums, the dentition, see if there's any bleeding. Of course, we always look at the mucosal. Look at their neck for symmetry or tenderness, any swollen lymph nodes. When we look at the thorax and lungs, we're of course going to inspect to see if for symmetry. We're going to palpate, percuss, and auscultate. And this diagram here, it shows like the mid-clavicular line here. I think, did we look at that in lab? Maybe we're going to do it this way. We look to see if the trachea is midline. We want to make sure the trachea is in the middle. There are certain things, trauma that can cause the trachea to deviate, there'd be a tracheal deviation. So that is one of the things that we do look at. Respiratory rate, we look at the how fast they're breathing, we look how deep, we look if they're having any difficulty. We check their skin and nails. Is there any cyanosis? Is there any clubbing of the nails? Here again is the palpation. It talks about the tracheal position again. Feeling, you put your hands on their back and you can feel as they are breathing in, breathing out. You want to put your thumbs next to one another. And as they're breathing, you will see that it's typically about 1 inch there between your thumbs as they're breathing. We check them for tactile fremitus. That's where you put your hands in the back as indicated on this diagram, and you compare the intensity of the vibrations in each area as they say 99. We auscultate the lungs. We auscultate from the front and sides and back. You can see the different positions here, and it goes almost like a ladder position. As you can see, it goes across, down, and then down. When you get to these points here, you're going to be down a little bit further out. Underneath, you can hear the on the side of the body, you can hear the lungs, and then of course in the back, you've got your different markers. And again, you just kind of work down, almost like a ladder. And we're going to practice this in lab, so no worries. There we go. Couldn't get the slide to change. This is when you percuss. You're going to hear different, each different area is going to have different sounds. Like the stomach is going to be more of a timpani sound, and that's because it's hollow. The liver is going to be more dull because that's pretty much a solid organ. You're going to have some resonance over the lung tissue. It's a very flat sound over muscles and bones. You don't really hear a whole lot. It's very flat. When you auscultate, you have three different sounds. You have bronchial sounds that are over the trachea, bronchiovesicular are over the main bronchi, and then basically over the bronchioles, the bronchi, the bronchioles, you're going to have vesicular breath sounds. So there's different breath sounds, vesicular, bronchovesicular, and bronchial. As people get older, they're going to have some different effects on their breathing. They'll have reduced chest expansion. This is a big one. They have a decreased cough mechanism. Their body doesn't tell them to cough as much. And then even if they do cough, often their muscles are not as strong, so they are not very effective at coughing. Their immune system decreases, and they have more gradual responses to changes in O2 and CO2 levels. So some different conditions here. Like COPD, typically people would have a barrel chest. With pneumonia, you're going to hear some like low pitches with some gurgling sounds in their lungs. They'll have a frequent productive cough and shortness of breath. We always encourage them to cough and deep breathe. You can hear some stridor. That's a very harsh barking sound. Inspiratory crackles, and it's almost like Rice Krispies sounding. Like when you pour milk into Rice Krispies, you have snap, crackle, pop. Blood gases. We're going to talk about blood gases later. We're not really going to worry about these at this point. The tidal volume is the amount of air that's exchanged after a normal expiration. Some different diagnostic tests. Pulse oximetry. This is what y'all are more familiar with. That's what we typically will put like on their finger and check their oxygen saturations. ABGs, arterial blood gases. Usually in a hospital, respiratory therapy does these, and it basically takes a reading between their pH level and CO2 and HCO3, and we will learn how to understand what the ABG levels, how to interpret them and what they mean. This just shows like the pH level. This is normal. Anything below that is acidotic, and this is alkalosis. Some different things here. Hypoventilation. That's when often the CO2 is elevated and respiratory acidosis results. Again, that would be something that we would look at with our ABGs. And hyperventilation, that's the CO2 is decreased and causes respiratory alkalosis. A lot of this is related to ABGs. And again, honestly, in this class, we're not going to be talking about ABGs. You'll learn that in med-surg. Oxygen saturation, normal range is 94 to 100. Bicarb is, it's alkaline, and typically when somebody is acidotic, they'll need some bicarb to help bring their pH level. CO2 monitoring or capnography, that is, you can put electrodes on the skin, or some people that have different face masks, or if they're intubated, they'll have a little detector on it that will determine the CO2 monitoring on that. Some diagnostics also, sputum. That would be people either expectorating, that would be having the cough and having a productive cough, or we could do suctioning with if they're having some blockage, some obstructions, we can suction it out and then send that off to the lab. And typically the lab can say, okay, yes, there's this, bacteria in it, or this is viral, or whatever it is. Different skin tests for respiratory. Now, of course, we have allergies. We test for allergies. We test for TB. And y'all know what that's about because we have that done here in nursing. You have your PPD done. Bronchoscopy. That's basically the scope. It goes down into the bronchioles and it actually visualizes. Sometimes they go in and obtain specimens. If there's an infection, they can go take out specimens, or they can even remove mucus or foreign bodies when they do that. Lung biopsies can be done. Often it's done through a transthoracic needle, a needle aspiration. So it's usually not terribly invasive. Could have an open lung biopsy. That's not as common. Obviously, anything with this you want to monitor for any kind of respiratory distress. A thoracentesis, that is typically if there's like fluid in the lung, and it's usually ultrasound guided, and they will go in and pull out some of that fluid and can test it for pathogens or sometimes cancer. Pulmonary function test, that happens a lot with people that have asthma. They go have these tests done. It's a lot of times they'll sit in a certain, it actually, the way I've seen it, it almost looks like a phone booth, except it's all clear, and you have like a breathing apparatus, and a respiratory therapy works with you to tell you to breathe out. Breathe out as much air as you can, and then even put your mouth over the mouthpiece, and then even try to breathe out even more, or they'll tell you to breathe in, and it basically just measures all your different lung volumes, and it will help. This is one of the things they do to diagnose asthma. Of course, radiology, we can always do chest x-rays or CTs or MRIs. Pulmonary angiograms, and our PET scans. All right, so that is basically it for this chapter. If you have any questions, please let me know. Thank you.